Welcome back to the deep dive. Today we are wading into some murky waters, quite literally actually. We're looking at the digestive system, specifically the colon. Now, before you tune out thinking, oh, this is just about stomach aches, stick with us. We're actually looking at a high-stakes case of mistaken identity inside the human body.
It really is.
It's a topic that affects millions, but the nuances, it's often completely lost. And to guide us, our entire discussion today is based on material from Dr. G.S. Raju's YouTube channel.
And that's so important because this really is a detective story. Having that visual evidence from the source material is, well, it's crucial. As we're going to find out, actually looking inside the body changes everything.
Absolutely. So let's set the stage. When I hear colitis, I just think inflammation. That's the Latin root, right? Itis means inflammation.
Spun on, colitis is simply the descriptive term for inflammation of the colon. But, it's like saying your car has engine trouble.
Right. Doesn't tell you anything.
Exactly. Does it mean you're out of oil?
Right.
Did you blow a gasket? It's just a label on a box. And our job today is to open that box.
And that distinction is what we're hunting for. The difference between a surface-level irritation and a full-on structural disaster. But the research makes a really strong point at the beginning.
Oh, yeah.
You can't understand what's broken until you know what fixed looks like. We need a baseline.
Right. You have to. If we were to shrink ourselves down, magic school bus style, and stand inside a perfectly healthy colon, the architecture is very, very specific.
I loved how the source broke this down. It's not just a tube, it's layered.
Think of it like a wall in your house. You've got the wallpaper on the surface. That's the mucosa, the inner lining.
Okay, the mucosa.
Then directly behind that, you have the drywall. That's the submucosa.
Got it.
Then you have the studs, the framing holding it all up. That's the muscle layer. And finally, the siding on the outside of the house. That's the serosa.
Okay, that makes sense. Wallpaper, drywall, studs, siding, mucosa, submucosa, muscle, serosa. So in the videos referenced, when the camera is panning around a healthy colon, what are we seeing?
You're seeing this really distinct geometry. A healthy colon isn't smooth.
What?
It has these sharp, kind of triangular folds called haustral folds.
Haustral folds, and they should be crisp.
Very crisp, sharp edges. They give the organ its segmented look. And the wallpaper itself, the mucosa, it should be shiny.
Shiny.
Yeah, moist and reflected, almost like the inside of your cheek.
There was one other detail mentioned that I thought was a great tell for health, the blood vessels.
Yes, that's huge.
Yeah.
Because the healthy lining is so thin, you should be able to see this delicate network of blood vessels running right underneath it. It's called the vascular pattern.
Okay.
If you can see those veins clearly branching out like a river delta, you're usually looking at healthy tissue.
So sharp folds, shiny surface, visible veins, that's our before picture, our baseline.
That's it.
Now, let's bring in the chaos. The two big heavyweights we need to distinguish between are ulcerative colitis and Crohn's disease.
The big two of inflammatory bowel disease, yep.
Let's start with ulcerative colitis, or UC. Based on the reading, this one feels, almost weirdly disciplined. It follows a very strict set of rules.
It does. If UC were a villain, it'd be an obsessive-compulsive one. It has two main rules it almost never breaks. First is the depth. Remember our house analogy?
Wallpaper, drywall, studs.
Ulcerative colitis is strictly a mucosal disease. It just attacks the wallpaper. It goes after that inner lining, but it almost never digs deeper.
So it doesn't touch the studs or the siding?
Yeah.
So it's painful, it's bloody, but structurally, the house is still standing.
Exactly. It's a surface-level problem. The second rule is the pattern of spread, and this is the key. UC is continuous.
Meaning that it doesn't skip spots.
Never. It acts like a rising tide. It almost always starts in the rectum at the very bottom, and it just marches upward. No jumping. You will never, ever see a patch of healthy pink tissue between two red, inflamed patches.
That's a powerful image, a rising red tide. And the terminology changes based on how high that tide gets, right?
It's a literal geography lesson. If the inflammation is just in the rectum, we call it proctitis.
And if it creeps up around the bend?
Into the sigmoid colon, then it's proctosigmoiditis.
Which is a mouthful.
It is. If it reaches the left side of the colon, we call it left-sided colitis. And if that tide goes all the way up, covering the entire organ.
That's pancolitis, pan meaning all.
Precisely.
Now, I have to ask about this specific thing from the source because it sounds like a paradox. Pancolitis with backwash ileitis.
Yes. This confuses a lot of people.
Because we just said UC stays in the colon. But ileitis, that means the small intestine, the ileum. So did the rules just break?
Not exactly. So normally there's a valve between the small intestine and the colon, the the ileocecal valve. It's a one-way door.
The tide hits the wall.
But in severe pancolitis, where the whole colon is inflamed, that valve can become, well, incompetent. It gets swollen, it stays open, and the inflammation literally washes back into the very last few inches of the small intestine.
So it's not the disease attacking the small intestine, it's just spillover.
Exactly. Collateral damage. It's a crucial distinction because if a doctor sees inflammation in the small intestine, they usually think Crohn's. But if it's just this backwash, it could still be UC.
Okay, so we have this continuous surface-level scraping. What does that do to the look of the colon over time? We talked about those sharp haustral folds.
They're the first casualty. In chronic UC, the inflammation just smooths everything out. The colon loses its features.
It loses its texture.
Completely. The source describes it as becoming a tubular colon. In radiology, they sometimes call it the lead pipe sign. It just becomes this rigid, featureless, short tube.
Wow. No folds, just a pipe. It sounds like the organ has lost its personality.
It's stark.
Yeah.
And that rigidity affects its function, obviously. Yeah. But visually, it's a hallmark of long-term UC.
Okay, so that's the disciplined villain. Now let's look at the chaotic one. Crohn's disease.
Crohn's is the anarchist of the digestive tract. It follows none of the rules we just laid out.
The big word used in the material here is transmural.
Transmural. It means across the wall. If UC attacks the wallpaper, Crohn's takes a sledgehammer to the entire wall. It eats through the mucosa, the submucosa, the muscle. It can even blow right through the serosa.
So it actually creates holes.
It's structural failure. And because it digs so deep, the ulcers look different. In UC, you see shallow erosions. In Crohn's, we see deep fissuring ulcers. They look like cracks in dry earth.
And what about the rising tide pattern?
Doesn't exist in Crohn's. Crohn's skips around. We call them skip lesions. This is the classic signature. You might have a horrible ulcer, then 3 inches of perfectly healthy, shiny colon, and then another ulcer. It's patchy.
Non-contiguous.
Exactly. If you see normal tissue interrupting the inflammation, you are almost certainly looking at Crohn's.
And it's not just in the colon, right? The source material lists a terrifying geographic range.
It can strike anywhere, mouth to anus. But, the most common presentation is ileocolonic. That means it hits the end of the small intestine and the right side of the colon.
Which is interesting because UC usually starts on the left.
Generally, yeah.
Yeah.
But Crohn's is just, it's unpredictable.
I want to circle back to the transmural aspect, that sledgehammer effect, because the complications listed for Crohn's seem much more mechanical.
They are. When you have inflammation tunneling through the wall, you get fistulas.
Define fistula for us.
It's an abnormal tunnel. Imagine an ulcer that just keeps digging. It goes through the colon wall and into whatever is next to it.
Oh, wow.
It could tunnel into the bladder, another loop of intestine, even out to the skin.
It's horrifying.
It's a major complication. And of course, if you have a tunnel leaking bowel contents, you get an abscess-pocket of infection.
Yeah.
We just don't see those things in UC.
Okay, so if I can summarize the cage match, UC is surface level and continuous. Crohn's is deep, destructive, and patchy.
That is the fundamental difference, yes.
But here's what confused me at first. The source emphasizes that the actual endoscopy looking inside can be really difficult.
Incredibly difficult. Because here's the catch. Inflammation looks like inflammation.
Red is red.
Red is red. If you zoom in on 1 square inch of sick tissue, you often can't tell the difference. The material breaks down the visual signs that apply to both conditions.
Okay, so let's walk through what the camera sees. It starts with the folds getting swollen.
Right. Edema. They lose their crispness.
And the shiny look.
That disappears. The texture changes to something called granular.
Granular. Like sandpaper.
Exactly like wet sandpaper. The light doesn't reflect. And because the tissue is so swollen and granular, remember those beautiful blood vessels?
The vascular pattern.
They get obliterated, hidden. You can't see the veins anymore. So loss of vascular pattern plus granularity, that's the universal sign of colitis.
And then there's a word that kept popping up. Friability.
Ah, yes. Friable means fragile or crumbly. In this context, it means touch bleeding.
Touch bleeding.
If the endoscope just brushes against the wall, it starts to ooze blood. It's just that raw.
So if a doctor sees granular, friable tissue with no vessels, how do they know which disease it is?
They have to stop looking at the texture and start looking at the map.
The context?
Precisely. They pull back. Is this continuous from the rectum? Or are there healthy patches? Or are there deep fissures?
So the diagnosis isn't in the what, it's in the where and the how.
Ideally. But, sometimes it's tough. The findings can be indeterminate. But usually the pattern is the smoking gun.
Okay, we've covered the big two, but the source warned about imposters.
Yes, this is crucial because you can't treat an infection with immune suppressants. You could make the patient much, much worse.
So what are the lookalikes?
Infectious colitis is the big one. Bacteria like E. coli, salmonella, they can make the colon look red, granular, and friable, just like you see.
But that's usually more sudden, I'd guess.
Usually, yeah. Acute. Then there's ischemic colitis.
Ischemic means lack of blood flow, right? A gut attack.
Exactly. If a blood vessel gets blocked, that section of the colon gets inflamed, and it looks segmental.
Ah, because of the blood supply.
Right, you'll see a sharp line where the blood flow stops. And it usually happens in watershed areas, places where the blood supply is a bit weaker.
So if you see a sick patch there, but the rectum is fine, think ischemia.
Correct. And then finally, you have drug-induced colitis. NSAIDs, like ibuprofen, can sometimes do this.
Now, I want to pivot to the finale here because this was the part of the material that genuinely blew my mind. A condition called diversion colitis.
This is a fascinating mechanism. It's the real aha.
It seems like a paradox. So this happens in patients who have had surgery, maybe a colostomy, where their stool is diverted into a bag.
Right, so the waste stream is rerouted. It never reaches the rectum. The rectum is left there, out of circuit.
So the rectum is just, it's sitting there empty, clean, resting. Logic says that's a good thing. It's on vacation.
You would think. But in reality, the rectum starts to get sick, it gets inflamed, becomes friable and granular. It develops colitis because it's empty.
Why? Is it? Is it lonely?
Biologically, yes.
No?
This is the amazing part. The source explained that the cells lining the colon, the colonocytes, don't get all their food from your blood. They get about 70% of their fuel directly from the stool passing by.
Wait, the colon wall eats the poop.
In a way, yeah. The bacteria in your gut produce short-chain fatty acids, especially one called butyrate. The colon cells need that butyrate for energy.
That is wild. We think of waste as this toxic stuff we're getting rid of, but our body is still harvesting from it until the very last second.
It's a symbiotic relationship. So when you divert the stool, you are literally starving the rectum.
So diversion colitis isn't an infection, it's starvation.
Exactly. It's the organ crying out for food.
And the cure?
Feed it.
Just feed it.
The cure is to re-anastomose, reconnect the plumbing. Once you let the stool flow back into the rectum,
the tissue heals.
It clears up. The inflammation just vanishes because the cells are getting their lunch again.
That is such a profound concept. It just highlights how interconnected everything is.
It totally challenges the way we view waste. It's not just garbage. It's a necessary part of the ecosystem inside us.
Incredible. Okay, we've covered a lot of ground today. Let's try to bundle this up.
Sure.
We started with the healthy baseline. We're looking for sharp haustral folds, shiny mucosa, and a clear vascular pattern.
And when that goes wrong, we look for the pattern.
If it's ulcerative colitis,
yeah,
it's a surface climber, mucosa only, starts in the rectum, moves up in a continuous tide, and eventually it turns the colon into a lead pipe.
Correct. And if it's Crohn's, it's a transmural destroyer through the wall, creating fissures and fistulas. And it skips around, healthy, sick, healthy, sick.
And the investigation requires a detective's eye, granularity, friability, obliterated vessels, but you have to zoom out to see the map.
And don't forget the imposters. It could be infection, low blood flow, or in the case of the hungry rectum diversion colitis, it could just be starvation.
It really brings home the idea that you can't judge a book or a bowel by its cover.
You really can't.
Before we sign off, what is the one provocative thought you want to leave our listener with?
You know, this whole discussion makes me think about the limitation of a snapshot diagnosis. We want one test or one image to give us the answer. But in the colon, a snapshot of inflammation it lies to you. It all looks the same. The truth is only found in the context, the distribution, the depth, the history. It's a reminder that in biology, context is often more important than the content itself. You have to look at the system, not just the symptom.
Context is more important than content. That is a powerful takeaway. And a final reminder that all the insights discussed today are based on Dr. G.S. Raju's YouTube channel.
It's a fantastic resource for actually seeing these patterns.
Well, thank you for guiding us through the twisty turns of the digestive tract. And thank you to our listeners for diving deep with us. We'll catch you on the next one.